And thank you for having us because we're happy to be here and always happy to collaborate with our community partners, especially around issues as they relate to homelessness. I'm going to ask our bureau chief, Arnisha, if she would start with introductions. And then there are three other emergency services staff present who will take
Good
part in
morning.
the training.
Oh, I'm sorry. Good morning, everyone. I'm Arnisha Moody. I'm the Client Services Entry Bureau Director. We like to think of ourselves as front door services. Thank you for coming out and for learning more about emergency services and the services we provide to the community.
Hi, Ollie Russell. I'm the Assistant Director for Behavioral Health Services and Liaison to ES, and also Liaison to the CSB.
I think you're
You're on
muted,
mute,
Danny.
Danny.
Sorry. Good morning. My name is Danny Scanlon. I'm one of the emergency service clinicians.
And my name is Patrice English, and I'm an assistant manager here in Emergency Mental Health Services. So I will tell you what will be most meaningful for us and probably for you is if we can have an interactive session. Please, by all means, raise your hands, ask questions. We're going to provide you with an overview of emergency services and what we do, but you can put questions in the chat if you don't want to go on camera, just so we can cover a variety of situations and make sure we're meeting your needs. Okay? Thank you. I'm just going to say next, Trina, whenever we're ready for the next slide. So just a basic overview of emergency services. We provide services to anyone who is experiencing a psychological or psychiatric emergency in Arlington County. We serve people regardless of age, and unlike a lot of other county services, people don't necessarily need to be residents of Arlington in order to work with emergency services. So we have people who come to visit, people who are just passing through, and we continue to work with those people if they're experiencing psychiatric distress while they are currently in Arlington. We are 24 hours a day, 7 days a week. We are physically located in the Sequoia Plaza, Sequoia 3, but we definitely do go out into the community, and we are considered county essential personnel. So you can see by my little icons that whether it's raining or snowing, we have Thanksgiving coming up, whether it's sunshiny, no matter the season, emergency services is on duty. And again, our main mission is to do crisis evaluations, interventions, stabilization, and short-term support, and also to link people to other services if necessary. Okay. Next, Trina. So these are some of the goals of emergency services. Ali, do you want to talk about that?
Jumping on the line there. Sorry, I'm having some issues with the computer freezing on me here.
I'm sorry.
I'll just go ahead and we'll see how far I get. Well, it'll be fine. So we have three main goals in emergency services. First is that we want to intervene. The three main prongs that we have to look at are preventing harm to self, preventing harm to others, and then assessing capacity. But you'll also note on the slide that we also talk about, damage to property as well. We have the mandate of following the Code of Virginia to determine those dangerousness to self, dangerousness to others, and inability to care for self. And there's 14 modules that we do that are state trainings that we have to go through, and then about another 80 hours where we're shadowing people and then observed ourselves and developing that. And even with that, when we have specific cases that we're working through, we tend to staff them and make sure we're getting multiple perspectives so we don't miss our own blind spots. People come in with a high degree of need, and it's easy to hear what they're saying and sometimes not think outside of that narrative that they're giving us. And so we do reach out and confer with our with other staff, with our supervisors, and make sure that we're seeing the full picture as well as we can in the moment. So there is a very much a team approach to it. So, and then the last thing is considering the least restrictive option. It is a state mandate that whenever we're going through and looking for what is the appropriate response in this person's psychiatric distress, our goal has to be, and we have to be able to show that we considered the least restrictive option. So instead of hospitalization, would they be eligible for a CSU? Would a calming room be sufficient? Would connecting to same-day access and having an appointment and coming in and getting established in services? There's a number of different things that we look at, and as our community providers, many of you are on the phone. We often coordinate and collaborate with each of you when we're looking at what are least restrictive options and how do we build a safety net around each of these clients. So next. So with that, I'm going to turn it back over to Patrice or Danny. I'm not sure who's taking this slide.
I could take this one, Ollie.
All right. I just did the modules on this last week, and so I could tell you what I remember, but I might not get it all exactly straight. But Danny knows it a lot better than I do.
Oh, well, I hope you can correct me then if I'm wrong. So to Ollie's point, this is not just an Arlington mandate. This is a statewide mandate through the Commonwealth. Regards to the criteria for hospitalization, it's also each locality interprets it a little differently, so it is hard, and we have to all keep up with, especially with the Nova area. Various legal entities are involved. We have magistrates, special justices, judges. When we present clinical to the magistrate in order to obtain or to prove that we want that this person meets hospitalization, we have to have clear and convincing evidence. So that leads us a lot of times when we are on the phone with other stakeholders or yourselves, we are asking so many questions because we have to present all of that information to the magistrate in order to obtain a petition, even for further evaluation. So it's very specific criteria. Other thing, so I would break down, like the ECO is an emergency custody order. That is what we can place the client under. It either could be paperless or paper. Paperless would be issued by ACPD usually, where they're out in the field and they feel that the client meets one of the three prongs and they feel it's necessary for emergency services to do an assessment to determine what the appropriate level of care should be. And in that 8 hours, we have time to bring the client to the hospital, have them medically cleared, COVID screened, and then start the process to, one, we need to evaluate them within an hour, and then two, we need to start looking for a bed for them, in addition to calling other stakeholders, therapists, yourselves, to get even more collateral information and obtain collateral from family or other localities if they've been served by, anywhere else in the Commonwealth. We would call their CSB. If we feel detention is necessary, then, like I said, we move forward with the detention order, and at the end of the 8 hours, we would petition for a detention order to a hospital that has accepted the client. Patrice, do you have a correction? You're on mute.
We're going to go into some of that in more detail.
Okay.
I think, but the biggest issue is just that I know sometimes it may seem, well, what are the rules? What are the rules? And the rules are issued to us. We have to follow the rules. So we may be asking a lot of questions because a lot of questions get asked of us. And this is just the way it is. It's the standard for the state. So it's not Arlington, it's not Fairfax. It is just the standard. It's the way it is for Virginia. Next slide, please, Trina. So I think Ali and Arnisha and Danny and I are all going to just talk to you a little bit about the questions, because we do ask a lot of questions. And the first thing I want to say about that is do not be put off when we ask questions. It is because we are interested, and in our minds, we're trying to build a case for that emergency custody order or that detention order. So I have a list of questions here. They're by no means exhaustive. And you may say something to me if someone calls and say, this guy is, maybe he's making threats. And I may say something like, how long has it been going on? And that's important because the magistrates will often ask me, well, how long has this been going on? That they understand that people who have mental illness are not always symptom free. And sometimes people have symptoms that break through despite being on medication, despite being housed, despite being in treatment. And so they will ask us, so what's changed? What's different now? Why is this a problem today and it wasn't a problem yesterday? So some of the other questions might be, I don't know, Danny or Ali, if you want to say about people's self-care. Why do we ask those questions? About eating and sleeping, those kinds of things.
Well, yeah, and I was going to follow up a little while Danny's getting camera set up. I was going to follow up a little bit on the question that you started out with, Patrice. So anytime you're doing a diagnosis, you always ask intensity of symptoms, you always ask for duration, and you always ask for frequency. Those are standard to any diagnostic situation. And so that's why you also find those same types of questions in the assessment. And when we're asking those types of questions, it is actually helpful for us. If the answer is, I don't know, if you just say, I don't know, that's perfectly fine. What we're trying to do is assess where there's gaps in our understanding and what we do know, so that we can figure out what we need to focus on in an assessment. So it's really helpful for us if we know that you don't know something, or that's something that has been reported by somebody else, as secondhand information. It's really important for that as well. Those next two questions are really important too, because part of what is happening is we might be meeting the client for the first time. There's many clients who come through ES who we actually have a fairly long history with and we know them pretty well. But there's a lot of people who come to ES for services and we've never met them. And so we don't know what their baseline is. We don't know what is a normal day for them versus an escalation of symptoms, or there's been stressors that we're not aware of that may have led to more symptoms. So it's really helpful for us if we know where there's been changes in their eating, sleeping, activities of daily living or daily care, or just basic things like that. Help us to start identifying when a change occurred and start identifying, is it getting worse? Is it leveling off? How far from baseline are we? Those are questions that help us in making an assessment of somebody that we may have just been meeting for the first time, but that you may actually know a little bit better than we do. So Danny, I don't know if you had things you wanted to answer or add to that, or if you wanted to try the next question.
Where did you leave off? For daily activities. Just back to your point, I mean, it's hard sometimes when we don't know someone, especially if we are reviewing for the third prong, which is inability to care or protect themselves. Without knowing the client, we don't know what what their baseline is. And so we have to be able to establish that that person is vulnerable in the community. And if so, why? And that's another point that we have to drive home with the magistrate, which is not always an easy sell.
Right. At times that one really does feel subjective to the magistrates. And One of the things that we have found, and I'm sure each of you as community providers have noticed, is that our clients are so resilient and they're so creative, and they find ways to accomplish the tasks that are important to them. And so it's really hard sometimes to tell the difference between when they're really in need and when they're really at their baseline. So that background information is really helpful to us.
And I think you all would be surprised because the magistrates would, you all know, they work right around the corner from you. So, some take Metro in. I may present them with a petition for someone and they're like, I know this guy. I saw him this morning. I saw him on my way to work. He seemed fine to me. What's happened that, he was fine. He was his usual self. And so we really do have to drive home the point. That's why we ask the questions. It's not to create a barrier. It really is to build a bridge so we can show that there is cause, particularly on that prong where we need to be able to show that people are not caring for themselves. We ask about medications and whether or not they're taking medications. And that's not just psychiatric medications, it's all medications. If you know whether or not they are taking medications, if their medications changed, sometimes people are very selective and they may be taking some, but not all. And if people are not taking their medical medications and they need them or not getting medical treatment, we need to know that too. We will ask about health concerns because, and Danny mentioned this early, we have to rule out that there's any underlying medical cause for the current psychiatric presentation. And particularly in some of our more vulnerable folks and some of our senior adults, there can be something like a urinary tract infection or a bladder infection that can cause and manifest in psychosis if the infection gets bad enough. And we see that a lot. So we need to ask lots of questions about health, if there are ongoing health concerns or new health concerns. We will ask also if people have mentioned suicide or thoughts of hurting others. I know things can be tense sometimes in the shelter, and there can be lots of sometimes interpersonal discord, but we're talking about more than that. We are talking about someone who is very intentionally, seems to be planning, thinking of, figuring out a way to hurt themselves, take their lives, or to hurt someone else. Particularly of concern is when someone says, well, I heard, a voice telling me to hurt this person, or I think, like they have this kind of message from someone or feeling like they have to do something to someone. Like, I feel like if I need to punch this person or destroy this property or do something because they're responding to some sort of internal stimuli. And so we need to know that. And that's different than just having a bad day and feeling like you really want to, punch the wall or something. We're talking about something that's really intentional. We will ask if there are signs of self-injury. If you notice that there is bruising, if there are burns that seem to be self-inflicted from cigarettes, sometimes there is cutting. Sometimes, again, the bruising, sometimes I have seen a fingernail picking or skin picking to the point where the skin is broken, the fingernails are lifting off the nail beds. And so that kind of self-injury we want to be aware of, because it could be believe it or not, sometimes it's a medical issue, but there could be other things going on psychiatrically that we need to address. And then I'm going to ask Arnisha and Danny and Ollie, anything else to add about that, about the dangerousness?
I just wanted to add one thing, just to go back for a moment. I just wanted to make sure that we touched on that we also have to believe that the person is one of these three prongs, right? So first we satisfy for ourselves before we petition the magistrate. So we do a very careful examination and a look at the facts that are presented to us. And we need you in order to do that. And that's why we do ask so many questions. Once we satisfied for ourselves or for the supervisor or as a group or however we assess the person, then we go to the magistrate. We take it very seriously that we are detaining a person and we're removing them and placing them at a hospital setting for 8 hours or either 24 hours if we decide that we need to hospitalize that person.
Agreed. And one of the questions we also get asked by the magistrates are, what have you already done? And this speaks to what Ali mentioned earlier, that least restrictive option. The magistrate is going to want to know what's been tried. Have you increased medications? Have you increased the number of sessions that people are having? They want to be able to really know. Again, they take it very seriously when we are taking someone's rights away from them and placing them in a hospital. So they want to know, well, has the person been to detox? If it's, substance related, have you considered that this could be related to that, infection that they have? They will ask us, and they do ask. Part of their screening is also asking about medical issues, and could there be a medical issue that could be causing the current psychiatric symptoms. So I know it can, in the heat of the moment, it can be very frustrating. You want help. And this is the first step to getting that help, is to ask some of these questions that we need so that we can, again, make the case that someone meets that criteria. Okay. And again, any questions that you all have right now, please feel free to type it into the chat, but we will have time for questions later. But anything you think of, by all means, feel free to type it in the chat. Okay. Anything else, Ali, you wanted to add? You or Danny?
Yeah, I was just going to add, I think one of the really interesting things about this kind of work is that we're clinicians, but in some ways we're preparing documents for court. So we almost end up being lawyers. We're really developing a case. We're trying to document a case. We're trying to present it to the court so that they can make a decision. And in that sense, they're going to make the final decision. So it doesn't always go our way. It usually does. But that's why it's so important that we collaborate with each of you to understand the circumstances of the client so that we can give the best possible picture to the court, and then obviously then they'll make their own decision and we go from there.
And one thing, again, I just want to stress the weight of what we are told by staff is so heavy that on the document, and the document that we have to present prior to getting someone detained is a 17 to 19 page document. And it asks, where'd you get this information from? Who told you? And it goes through many, many hands. So we write it, we have to present it to the magistrate. It follows a person to the hospital with the treatment that they get. It goes to court, their attorney sees it, another independent court evaluator sees it. And so I'm saying, well, Arnisha Moody from the shelter said that the client hadn't gotten out of bed and didn't bathe for 17 days and on and on and on. And we have to attribute those sources. So what you tell us, we are taking notes and taking it seriously, because it becomes a part of that record that we have to create so that we are being respectful and just in the treatment that we give people. Next slide. So to underscore all of that, I want to make sure that you all know emergency services is here to help. And what help looks like can be different for every person that we see. I know some of you are very familiar with our office here at 2120, but I wanted to show you the front of our building because we have a separate entrance. And if you look at the slide, you can see where it says CIT Emergency Services. And we have a separate entrance. We have an area that has calming rooms in them and interview spaces. We have our offices, and again, we're open 24 hours a day, 7 days a week. So when we are here to help, we do any number of things. For example, we can do assessments right there in our office. Sometimes we will say, hey, is the person okay to cab over? Can we cab them over? That kind of thing. If they are well enough to be cabbed over and we're not able to respond to a shelter immediately, we'll cab them over, and then we can try and leverage some supports around them, see what we can put in place, because our goal is not always going to be inpatient treatment. Our goal is going to be stabilization of the current emergency in the least restrictive possible way, in the most humane way, meeting the client's needs the best way that we can. So you can see on the slide also, we have like a little mobile device. Because of COVID, we have been able to expand our ability to do telehealth assessments, which we can see folks in real time. It's our hope to be able to expand that to the shelters because we know you all have a lot of need. And so when someone calls, for example, at the hospital, or even if it's an officer in the community, we can say, hey, let me see what's going on. And we can pull up on our computers or laptops, or sometimes even on our county cells. We can actually talk to a person, we can hear, we can see what's going on in real time. And that helps inform our decision making. Again, part of our help may be linking someone to treatment. It could be coming into the same day access. And we're so fortunate to have same day access right here as part of our bureau, because they have just been phenomenal. Sometimes getting people medication on the same day at certain times, which is great. So we want people to be linked. Sometimes it's a referral to other treatment providers, whether that's an inpatient hospital for medical reasons, or it could be just some other treatment providers that have services like the CSU, or crisis stabilization units, that Ali mentioned earlier. And we also have other regional agencies that we partner with, and we want to use and leverage their support when we have people who are having psychological distress. One of those you may hear us talk about is REACH, which is a program for people who have intellectual and developmental disabilities. They can do a lot of the same kind of support that we provide, but their support is going to be ongoing. So sometimes when there is a crisis, we can link someone to REACH immediately. We've done we do joint assessments with them most often, and we can bring that crisis to some sort of resolution. Another one of the agencies we use is CR2, and that's a children's regional crisis response. So that would be more maybe for some of the family shelters with children, but during COVID, they have actually raised their age up to age 22. So if you have some young adults who are in your shelter that meet that criteria, we can also work with CR2. CR2 will provide services, psychiatric and therapy services for about 45 days free of charge to individuals. And they can, again, help maintain that placement in the shelter while giving people the help and the care that they need in the least restrictive setting. Anything else to add, you all?
No, I think you covered it all, Patrice. I just wanted to add that we're going to be enhancing our CIC, and we're going to be doing some updates. and bringing on additional staff. So we'll share that information with you as it becomes available.
Thank you. Next slide, please, Trina. And we're going to let Ollie take it away when we talk about what's an emergency and what's a crisis. And we'll probably all be jumping in on this.
All right. And, as we're talking about this, I think this is actually one of the best slides for us to be able to have conversations. And if there's any questions, this is a great one to start with. So if you're watching this from home or from your office, if you want to just read through it and kind of look for where you've run into difficulties or where you feel like additional explanation would be helpful, please just raise your hand, pop it in chat, whatever works for you. This is definitely a slide that I think would really benefit from some good discussion. The state really breaks it down into an emergency versus a crisis, and this slide is taken directly from the training that we get from the state. So they look at what's an emergency, and that's where emergency services really is supposed to focus their attention, and what's a crisis situation. And in a crisis situation, our role is a little bit different. It might be technical support. It might be helping with referrals. It might be talking things through with a clinician. It might be, different ways of supporting. Within an emergency, our job is to assess, and it moves towards an ECO, TDO, and the thing, and that, like we said about the CIC with the calming room. So. Emergencies, what constitutes an emergency? And I'll just go through them quickly. So acting on a suicidal threat. And so we know there's a difference between somebody making passive statements about suicide, to suicidal ideations, to having an active plan, access to the means, all those kinds of things. We know there's a continuum there. So acting on a suicidal threat is an emergency. Homicidal or threatening behavior. Homicidal behavior is very clear. That one is, in terms of threats, but threatening behavior, that one can be a little bit more subjective. And so that one's one where we really have to talk it through and understand the dynamic and make sure that we really understand what is considered threatening behavior. And so that's one where we often ask more questions and try and understand more clearly. So self-injury needing immediate medical attention. And I believe, if I'm remembering correctly from the training from the state, their emphasis is on that word immediate. That's the word that jumps out. They're not looking to somebody scratch themselves. They're looking at, is there blood to the point where you really need to get to the hospital and get them some care, those types of things. And while that feels a little crass to put it in those types of terms and really think it through, we really want to look at, and again, it goes back to least restrictive environment. Where's the appropriate place for care? What's the appropriate level of support that this person needs for their current symptoms? Do they need to be in a hospital waiting room? Could they be treated in a less intensive setting that might also be less traumatic? Our hospitals right now are overburdened, and they're not necessarily the most therapeutic place to be. At least the emergency rooms certainly aren't. Emergencies can also include severely impaired by drugs or alcohol. Now, you'll also see in crisis situations that alcohol or substance abuse is listed as well. So again, this is one of those things on a continuum of when is somebody really in danger and unable to care for self, and when is this part of their, I wouldn't say part of their diagnosis, but when is it closer to a baseline for them? So that's one of those areas where we really have to ask more questions and understand, why is this situation different than the other times that they've been high or inebriated or using substances. Highly erratic, unusual, unpredictable behavior. When you see a psychotic break, when you see somebody running into traffic, when you see these types of things where they're putting themselves in danger again, it's not just are they being erratic. People have, as the police remind us when we talk with them about somebody in the community, people have the right to be erratic. They have the right to be loud. They have the right to do a lot of things that are uncomfortable for the people around them. But there's a difference between that and when they're actually in crisis or having a psychiatric emergency. And so again, that's one of those areas that's a little bit more subjective and probably worth kind of talking through. And then inability to care for themselves, impaired judgment. This is another one where we really work hard to understand what's their baseline, what level of support do they usually have that works for them. Are there things that have worked in the past for them? Was there a change that is disrupting their normal routines and their behaviors? Is there a trusted caregiver that's no longer available or that we could reach out to? All these things we think about in terms of reestablishing safety, ability to care for self, and least restrictive environment. We really want to keep people as close to home and things that they're comfortable with and feel safe and where they feel safe as possible. Hospitals are good for what we need them for, but least restrictive is the goal that we're usually aiming for. So crisis situations, and again, this shifts from being an assessment for an ECO, TDO, all those types of things. Crisis situation shifts, at least for emergency services staff, to how do we provide technical support, referrals, consider the option of the CIC, the calming room, some things like that that might help a person stabilize in the community and be a diversion from hospital. We do know that people need a step away from the situations that are causing them psychiatric distress. They often need a little break. They need somebody to talk to who can hear, who can normalize, who can reframe. And sometimes that's enough to help them stabilize. We had a number of people come into the CIC yesterday, and at the end of every, those couple hours we spent working with people, at the end of several of them, it was return to community because they stabilized, they were ready to get back to what they wanted to do, and they really didn't, feel like they needed to go to the hospital, and we didn't determine that they needed to go to the hospital at that time. But then there were others where we moved forward with assessment. So the crisis situations, talking about suicide or harm to others. As clinicians, we often hear people talk about, and especially make passive statements, I wish I hadn't woken up this morning, those kinds of things. And so we really try and work with them. And again, least restrictive environment, but supportive, and really take it seriously what they're saying to us. Displaying threatening behaviors. Again, this is, it's on a continuum from the emergency. So that's one that we could talk through. Self-injury, but not requiring immediate medical attention. Alcohol or substance abuse. Not taking their prescribed psychiatric medications. I know it sounds kind of funny, but it's not unusual for us to get calls from parents saying, my child was hospitalized 3 weeks ago and they're not taking their medications and I'm really upset. And I'm seeing them getting more symptomatic. And we find ourselves like looking for ways to provide support, resources, making that assessment. But again, there's a difference between an emergency and a crisis situation, and clients have the right to refuse medication. And then crisis situation, the last one there, emotionally distraught, very depressed, anxious, or angry. Unless those escalate to the point where a person is a danger to self, danger to others, or unable to care for self, is considered a crisis situation as opposed to an emergency situation. So those are some of the guidelines that we have to balance, and I'm going to say balance since many of those are on a continuum, but those are some of the things we have to balance as we're making decisions about what's the appropriate level of involvement and care for this client, and what are the best ways for us to support this client at this time. But Arnisha or Patrice or Danny, I don't know if there was anything else you wanted to add.
I just wanted to add that emergency services, we intervene in both situations a lot of the time. So you may call us about an emergency situation. You also may call us about a crisis situation. We take different tools out of our toolbox to address whatever the situation is. So if it's a person that calls in and says that their family member or their loved one is not taking their medication, that may be a referral to the outpatient therapist to let them know to re-engage with that client or to try to get them re-engaged in services. If it's severe impairment from drugs or alcohol, we may ask that the person be transported to the hospital based on the scenario. So whenever we look at these things, we individualize and we look at them. And if they don't rise to the level of us to consider whether the person needs to be hospitalized, we do intervene, but we intervene in a different way. Does anybody have anything else to add?
Hi, yeah, I just wanted to piggyback. sometimes when we get calls from other departments that the client's in crisis, and we do have to intervene different ways based on our staffing and what else is going on in the milieu. So unfortunately, we don't always have the time to explain to the other case manager on the phone why I'm not coming out to see your client or why I'm not responding in person to your call. And sometimes it's just because we have to triage everything that's going on. And we may have a very imminent case that meets the emergency, and the crisis, unfortunately, we have to, attend to afterward. So there is a lot of triaging that goes on internally with us. And I think, I've gotten feedback from the case manager, well, how come you came out yesterday, but you didn't come out today? And I think that's unfortunately day by day, minute by minute, shift by shift, it changes for us based on how much staff we have, if we have, just to kind of review that.
Thank you for adding that, Danny. I see we have a question.
Heather has a question.
Yes, hi. I think what Danny just said is fine because we understand what it is to be downstaffed. But I think when folks are in the shelter or that person's in front of them having a crisis, these people are not trained clinicians. And yet we have folks that are experienced, whether it's an emergency or a crisis. So yeah, we may be downstaffed or we may not have the ability, but I think some sort of explanation should be given to them to help appease the situation at the time, because they are not equipped to deal with this crisis. And if they are not given the knowledge or how to handle some of these things, the next step is that this person may be on the street. And this person may be even worse off because they have no other choice, because they have to protect the people in the shelter. They may have to let them go. And I think that puts the person from a crisis to an emergency. So I think we need to give them the language on what's the next step versus saying, hey, I'm about to get off. We don't have enough staff. Sorry, click. That's not something that I think that will be helpful. And I think you guys are helpful. I think to be able to give them the language, because as I said, they're not trained clinicians. These are people that are shelter staff, and a crisis in front of them, they need the language on how to be able to handle that.
So I thank you for your comment, Heather. I'm hoping no one is saying that I'm getting ready to get off, and I don't have the time to manage that. I'm hoping no one on the staff is saying that. But as far as us, if it's one or two people in there and they're dealing with a psychiatric emergency right then and there, and it's life altering for a person, they really have to attend to the person that it's life altering for. As I said before, we're going to be bringing on some new staff, and the new staff are really intended to help us with that. So we really want to get to a place where the ES clinicians are assessing for the emergencies and being able to help in the crisis, and then to have crisis workers who they can pass cases off to, and people can work more closely with that person. So an example of that would be if Danny's taking a call and she has to go out into the community, or she has something that's exploding in the office then, and it's only her and Patrice in the office, she picks up the phone and she says, this is a crisis situation. Hopefully in the future, she would be able to say, hold on, I'll be able to get a worker to discuss that with you and to talk about next steps for you and how to handle this situation better. But for us, sometimes the next step is a referral for services. So it may be, can you bring the person in for same day access? Does anybody else have anything to add?
Yeah, and Heather, I really appreciate you bringing up the situation, because we want to be able to talk about these types of things as fully as we can, right? So I think one of the other things is if there's ways for us to provide training, and we'd be glad to collaborate on verbal de-escalation training or some of these types of things that we have resources in, we'd be glad to share. And you're right, especially with unlicensed staff, we might need to kind of help build their skill set and their toolkits a little bit so that they have some of those things in place. It's really hard to learn in a crisis. That's like the wrong time to try and provide training. So we might want to think about what could we do that would help people be better prepared, as opposed to waiting for the crisis and then it's such a high stress situation for everybody. So I like that approach. But
That's very helpful.
Trina, I see a hand up. Yeah.
Yeah, and thanks. I wanted to build on this conversation because I also don't want folks to get kind of the impression that if it's not falling into this emergency category, one, we don't necessarily want folks to do that level of assessment and wait until it's an emergency. And so I think level setting some expectations that, when a crisis is happening, it may not always be responded to in a way that we would hope. But I also think that there are scenarios and cases where it's repeated behavior. We're afraid that it's going to start to escalate, and there's an element of wanting to kind of prevent things from going to an emergency. So do you have thoughts or suggestions, recommendations for folks to, how they might handle those cases? And if it's just kind of calling consistently as things ramp up, because you might see that our staff can de-escalate things for a moment, but then something triggers it, it starts right back up.
Sorry, go ahead.
I'm sorry. So we had talked about that, Trina, you and I, about how we can offer support to your staff. One was that we had talked about getting the iPad. We also talked about getting the CIT training for staff. So that 8-hour class in de-escalations. Unfortunately, what we talked about is Dallas is no longer with us. So when we get the next person, we also talked about meeting consistently. To debrief on situations and to see how we could get better at what we do and how we support you guys. It's not meant to be an excuse for us that we're short-staffed, because we still have our mandate and we still have our job to do, but we do triage the work. So how can we get better at triaging and making sure that we can offer in some assistance when there are crisis situations and you just need someone to talk to and to talk it out with? So I'm open to any suggestion around that. I mean, it's supposed to be a fluid conversation. We're a community trying to work together to address our needs. So I'm open to anything anybody has to suggest. Heather and I have had lengthy conversations about how we can support the shelters better. So we're very open to that. And it's not intended to be where you guys only call us in an emergency situation. This is really helping you to get a sense of the things that we respond to immediately. So when there are times when we say, the person is using alcohol, while we may say, well, we'll have someone call you back or we'll get you some help and somebody will follow up with that call, as opposed to when you say that a person is actively suicidal at the time, while we respond in real time then. I'm sorry, Ollie, you were going to say something.
Okay, I'm sorry. Go ahead, Ollie.
Yeah, no, I was going to add 2 things. And Trina, I appreciate it. I think there's a lot of wisdom in solve the problem while it's a small problem instead of wait until it's a big problem. I think there's a lot of wisdom in that. So it does sound like there's a couple different things that we could work on there. I think one of the areas that we really want to make sure that that ES staff are not being put in is enforcing rules. And we've had group homes or others that call us and say, this person's not following the rules and we really need this person to follow the rules to get along with the clients. And so we really need you to talk to them. Like, that's not our role. So we really want to make sure we're differentiating. That's why we wanted to talk about what's an emergency, what's a crisis. And even in a crisis, we still think that we have skills and support that we can offer and that we think can be of real value. But we want to make sure that we are in the role of clinical support.
One of the other things that I wanted to add related to this is that we have supervisory oversight 24 hours a day, 7 days a week in emergency services. So someone may call staff and it may be a crisis situation, but like you mentioned, Heather, in 2 hours, it will be an emergency because the person is going to lose their housing if there's not some sort of intervention. At that point, I would ask someone from the shelter or a shelter manager, just ask to speak to either any of the emergency services managers. And before we leave, I'll make sure we put our email addresses in the chat so everybody can have that. And just say, this is the situation, or you can call the office and say, we need to speak to the supervisor on duty or the supervisor on call. And we can try and staff it with you and just say, hey, you know, this person is going to be on the street, and let me tell you why that's not helpful for them and why they're too vulnerable to manage on the street. And we can look at it from that perspective too, because again, like Arnisha said, we want to support. It's just the kind of support we can provide at the time. Okay. So don't ever feel like you hung up the phone and say, oh, well, that's it. You know, we realize that's not it. We realize that.
Yeah, and we realize that things escalate, like, you know, left untreated and left with no help and no support, things get worse in the course of whatever the person is going through. So, you know, we're always open. You can always call us back. And like Patrice said, you can elevate it to a manager. Both of you ladies, Trina and Heather, you have my number and you can call me at any time.
And so we, you know, it is not unheard of. We see someone at, you know, 9 o'clock in the morning. We said, oh, we don't really think they meet detention criteria. And then we hear more, we get more information, or we can hear the person has done this, this, and they say, hey, you know what, we need to revisit that. And we can do another assessment, you know, in 2, 3, 4, 5 hours and say, hey, now this person really does seem to have passed that threshold that we need, so we can act on getting an emergency custody order. So we, you know, it's not like it's static. It's going to change, and we realize that. Anybody have anything else to add?
Good conversation. Thank you, guys.
It is a good conversation. Okay, so I'll add one more thing. We have rounds in emergency services at least 3 times a day, usually between 6 and 7 in the morning, at about 3:30 in the afternoon, between 2 and 3:30 in the afternoon, and then overnight, sometime between 10 and 11 o'clock at night. If folks at the shelters want to call us, they can say, hey, can we staff a case during your rounds? If you know something is escalating or building. We actually have a I don't know if I want to call it a hot sheet, but we do have actually it's several times daily communications of people we need to be on the lookout for, or who are on our radar that may be decompensating in the community. We get that kind of information from the outpatient teams, from community members, from family members. And so we are happy to get that information from you, because that helps us, again, start that process for gathering information, for understanding what's going on, to answer some of those questions. So again, we don't necessarily have to wait, you know, until the house is on fire. We can just say, hey, you know what, maybe there's something that's smoldering, and you can call us and let us know and say, hey, we really want to discuss that, or we really want to staff that with you. Next slide, Trina, please. Thank you. So we're moving in now to someone who has met that criteria for that emergency custody order, and Danny is going to tell you a little bit. She and I both will tell you a little bit about what happens over that 8 hours. I know 8 hours may seem like a long time, but it really isn't, given the task at hand.
No, it's not. And I touched upon this earlier in one of the slides. So the emergency custody order is issued either by police, which they could do a paperless, or we can petition to do a paper ECO, which means we fill out a piece of paper and we submit our findings and our request to a magistrate, and they review it, and then we discuss the case, and they either say, yes, you can move forward with the ECO, or no, you don't have enough evidence. The 2 outcomes of that. If the ECO is granted, at the time we complete an assessment of the client, Clients also brought to Virginia Hospital Center for medical clearance, where they do urine drug screen, EKG, blood work, and COVID swabs. In that time, we are also gathering collateral information, talking to case managers or any other treatment providers, family members, ACPD, or anyone who's had contact with a client, just so we can get the most information possible in order to make our decision. There is times if someone at the end of the assessment and after you've met with or talked to everyone who has given you collateral information, you're able to come up with a safety plan and choose a less restrictive alternative as opposed to inpatient psych. Then we will let we actually vacate the ECO. So not everyone that goes under an ECO is hospitalized. I don't know the percentage, so I wouldn't be able to say that. If we are moving forward with detention, again, we continue to then look for a bed. We have to search the entire state. We're mandated to do that. So sometimes, unfortunately, people do get placed 3-4 hours away in Hampton or Staunton. So it's we also have to work closely with family members who get, very upset that their loved ones are going so far away, they won't be able to visit. So we do a lot of support in that. In addition to that, keeping the family updated about the court hearings and how they can participate or be a witness in that process, because usually family members know that client best. The 3 prongs that we go over. So in order to hospitalize someone involuntarily, you have to meet criteria, which is imminent risk to self is prong 1. Prong 2 is imminent risk to others. And the third is inability to care or protect oneself. I think I mentioned earlier the third prong is sometimes very difficult to prove, because we do have a lot of people, like Ollie said, that are resilient, and they've been at baseline and surviving on their own for a very long time, and it's difficult. Not every homeless person or psychotic person meets criteria for inability to care. So that's where the collateral from all the case managers and the shelter and anyone who's ever had contact with this client is so important, that we gather all that information in order to make that case or that argument. Inability to care or protect self also would include, like, if someone is so psychotic and disorganized, and they're not able to protect themselves, and they're vulnerable to either law enforcement, getting engaged with law enforcement or getting hurt, that could also fall under inability to care or protect oneself. So it can be just your vulnerable population. Patrice, do you have anything to add to that for prong 3?
I disagree with what you said. Sometimes that is the highest benchmark to reach. And the magistrate will sometimes ask lots and lots of questions. The medical screening also it can be pretty time consuming. So sometimes, and I know this has sometimes happened, somebody may leave a shelter in police custody, at 10 o'clock in the morning, and the shelter staff is like, oh, great, emergency services is taking care of it, and, everything is going to be swell. And they get into the emergency room, and, the doctor may say, well, I'm going to give this person some fluids. Maybe they were dehydrated. The doctor may give them some fluids and say, hey, how do you feel about taking some medication? They might take some medication. And at that point that they seem to be stable and they have gotten some fluids and they're looking pretty good, they may no longer meet criteria, and they can be right back, at time at the shelter. Well, I'm back, here I am. And you're like, well, wait a minute, what happened? And again, I just want to stress, we are just not always in control of the process. We have very little control over the process. And so if someone is not, or the magistrate or judge is saying, we're not clear and convinced that this person meets criteria, because sometimes some sleep, some medication, some fluids, a little bit of food, and it just, a change of scenery changes everything in someone's disposition, behaviors, and symptoms. And when they have improved, unfortunately, we can't move forward, even if that improvement may not be long lasting. And I can just hear a magistrate in my head just saying, I'm not seeing it, I'm not hearing it, I'm not seeing it. And so things will happen, but again, it doesn't mean, tomorrow, if we need to reassess or we need to reevaluate or do something or consider a different kind of respite placement, just so they can maintain their shelter stay, we can discuss other options to address the kind of ongoing crisis. Okay.
And those things are meant to be checks and balances for us. So they're put in place for a reason, because the state of Virginia takes it very seriously when you're detaining someone and removing their rights.
Mm-hmm. It's a very, and Trina, you can go to the next slide, because this is a good segue into the temporary detention order. Our work is not done. Even after someone is detained, we follow people through the process of the court hearing. And that court hearing can be sometimes less than 24 hours after they've been taken into custody under an ECO. Sometimes it can be over a weekend if it happens on a Thursday or Friday, depending on which hospital it is. And then again, you're like, well, great, that person, is going to get some treatment, and I think things are going to improve. And unfortunately, things may improve for a short period of time. But again, someone has gotten some sleep. They have gotten 3 meals a day. They've been in a kind of more maybe sheltered environment. They've been taking some medications when they've been in the hospital. So by the time they come to that court hearing, and after they've been detained several days, they're looking pretty good. And they're telling the judge, hey, I'm feeling good, I'm looking good, I'm ready to go back to the shelter, I want to participate in treatment. And they have an attorney who is there, who is evaluating them, who is representing their interest, and also an evaluator from the court who will evaluate. And the judge often relies more heavily on what that independent evaluator with the court will say. And so we have people who may not be certified as meeting criteria for involuntary inpatient treatment. The judge will ask us, what have you already tried? The magistrate will ask, what have you tried? And so again, I'm going back to the questions that we started off with. When we are in court, like Ollie said, we have to pretend like we're attorneys almost, because we have to say, well, hey, he said he's going to treatment, but I have it on authority that, from shelter staff, he didn't get out of bed for a week, that his therapist came to the shelter, he refused to meet with his therapist, he's missed, 7 doctor's appointments in a row, they've rescheduled, he still won't go. So that's part of the reason why we need that information, so that I can make an argument in the court and tell them, I understand he's looking good today, and this is what he looks like today. I am telling you, this is the information that was given to me by reputable sources from the shelter staff who were living and dealing with someone 24 hours a day, 7 days a week. So those are just some of the things that happen at court, where we really don't, we do the best we can with the information that we have. And so again, I know it can be frustrating when you're in the middle of a tense situation, but this is again part of the reason why we're just building this whole foundation. One of the things the magistrate and the judge will sometimes ask, and this happens with people, some of our clients who have been in and out of the hospital repeatedly, There was a gentleman who I think had been asked to leave the shelter and, was under an emergency custody order, and I was ready to move forward with the detention. The magistrate wouldn't issue it because the magistrate said that he didn't think the client would benefit for treatment because he had been detained so many times in recent weeks and there was still no improvement in his symptoms. He said, I think you need to try something else. And so, there we were. And, with somebody who was pretty impaired, but the magistrate wouldn't issue the order. And so, we want to say, okay, well, that's it. We will work with you all to come up with some other kind of plan and work with the client if the client is willing to try and come up with some other kind of plan in those instances. So those are just some of the challenges. And, again, when people give me information, it is just so incredibly helpful to make my case and make our case for the best care for the client. Do any of you all have anything else to add? Next slide, please, Trina. This is the really good part. We want to thank you all for being here and giving us your attention. But again, we like to be interactive. We really want to, Trina said, when you do this, can you leave some time for questions? Yes, we certainly can. Here we are. So please ask questions. We're here to provide information and assistance.
Yeah, and I think one of the things that also be helpful as well is to be able to hear what do you need from emergency services? What would help you in crisis situations and emergency situations? What's really a benefit for you? How do we collaborate to really support clients through their toughest moments?
Hi, this is Mark from Bridges. Hey, Patrice.
Hey, Mark, long time. How are you?
Yeah, doing well, doing well. Good to see you.
Good to see you.
So as far as people walking in, what can people walk in during regular business hours?
Mark, our business hours are 24/7. So yes, I don't know what regular is, but people can walk in. Yeah.
Okay. I wanted to maybe talk with you later about a situation we've got at the shelter. And are you around later?
For you, I will be, Mark. Why don't you give me your number?
Sounds good.
Should I just call you at Bridges?
Yep. Yeah, you can. I'm
Okay.
at extension 137. Yep.
All right.
Thank you.
Patrice knows everyone.
No problem.
Yes. She's our national treasure.
We work very closely together with, I'm going to say Bridges. It wasn't Bridges then, but when I was working with Towing Path.
So just to touch on what Mark said, our Crisis Intervention Center is open 24/7, 365 days. So sometimes due to basing on staffing needs, we may not have someone to see them immediately when they walk in, but there's usually someone to be able to see any individual coming in who needs help. The person can walk in by themselves. You can drop them off. You can bring them. There are, when they come in, they can have one person with them, so they can come with a family member or a caring person to assist them. And it's really for the purpose to be able to talk to a clinician, to be in one of the calming rooms, or just to get some help to work through whatever crisis they're having. And as I said before, we're bringing on new staff, so we'll have the staffing needs to address the needs of the community better.
Arnisha, may I just follow? Hey, it's Danny. May I just follow up with that in regards to people coming? And also, if you're referring someone, if you could call us and give us a heads up, that would be great, because sometimes what happens is the client sometimes doesn't know why they're here or who sent them or what they're supposed to be doing here. And then we're backtracking and tracking the, finding who sent them and getting collateral information so that we can best assist them. So if you do have time and you are referring someone over, it would be great if you could call us. And then that way we could be prepared to receive the person and see who we can assign, so that the person, again, is not waiting all day for staff and we know what's going on.
Yeah, thank you, Danny,
Thanks,
for adding
Danny,
that.
for saying that.
No problem.
That's
Yes,
true.
yeah.
Um,
Any
anyone
other
else have
questions?
any
Oh,
questions?
so to touch on what Ollie said, is there any way that we can better support you in the work that you all do?
I think being available through at least the phone calls. I mean, we get clients that are definitely in crisis mode. They're dealing with a lot of abuse, a lot of trauma, a lot of PTSD. So just being able to have somebody that we can talk with about that is very helpful.
So, similar to what Danny said, if you guys make us aware of a person needing help, we can coordinate to facilitate that help. Or if you want to staff a case with us, or talk about some of the challenges that you're dealing with, you can email us or you can call us and ask for someone to call you back. And we would be happy to call you back. I mean, just give us a little grace because, sometimes we can't call you back in 15 minutes. We may not be able to call you back in 20 minutes, but know that we'll call you back, and we'll try to help you to help the client in need.
And it's also helpful if you could email all of us. So I put all of our emails in there because one of our other managers is on maternity leave, and I'm adding her too because she'll be back before you know it. But if you just email all of us, that way we can all see it. We can all look at it. If there are managers here during the day and the evening, they may get pulled into meetings. I'm here all night. So, if you email just me, you're not going to get an answer before 10 p.m. more than likely. But please just let us know what we can do to support and just email all of us, even if it's just a discussion.
And like Patrice said, you can ask to staff a case with us.
Mm-hmm.
So when we're doing rounds, if you have a case situation and you would like our input, you can ask to staff it with us.
Because our staff has amazing ideas, and we sometimes can come up with things in the group situation, and that's why none of us works in a vacuum in emergency services. We're always tossing things back and forth and discussing cases and trying to make plans for people.
And we have some amazing clinicians, like Patrice said, and they're able to help and to intervene, and come up with plans to help to be able to meet the needs of the community.
Mm-hmm. With a wide variety of different kinds of experiences and background and training. And so that's, I think one of the things that is special about emergency services, because people have, so many different specialized background experiences, that when we come together, it's just incredibly helpful.
I was going to give an extra moment for people maybe to chime in with questions, but if there isn't any, I just really appreciate all of your time. That I feel like I got a little bit of a sneak peek into your world and all the work that you do, and it was really helpful to hear sort of how you differentiate between crisis and emergency, the different thresholds, the different things that you're looking and listening for, and then also the other options, that it doesn't necessarily mean that we're waiting for an emergency that would go straight to commitment, but that there's other types of ways that we can intervene, and that opportunity to staff situations feels like a really solid option for folks where we think are kind of in that ramping up place and we want to try to do something more preventive. So I really appreciate the information that you shared with us and the time you're taking. And Anisha, yeah, to your point, I look forward to our, partnership, our kind of working together to think through how we can systematically, right, improve this coordination and access to your all services and all for the benefit of folks who are, I think, like Mark said, coming into programs with a lot of trauma, a lot of histories, right, that we're all well aware of. So unless there's other questions, I guess we'll wrap up. And thank you for sharing your contact information too, Patrice. It's in the chat.
Yeah, so please, you all can email us with questions later if you have questions. We're here, and we're here to support however we can. Thank you for this opportunity just to be able to have these discussions, and I just look forward to having more and working more closely together.
Thank you.
Thanks, everyone.
Thank you. Thank you for inviting us.
Yeah.
Thank you for all this great information.
Thanks. Appreciate it.
Thank you all so much.
Thanks, everyone.
Bye-bye.
Have a wonderful day.
I have to remember to stop recording.